is kind of going back, then we've got three approaches to fix the meniscus. As we all know, one is all inside repair, wherein we have meniscal devices where we try to put the stitch through the portal and fix the meniscus inside the joint. There are other two techniques also. One is inside out and outside in. Inside out, we need to have the Mender set, wherein you have zone specific cannulas where you want to target the meniscus to fix it, and the very easy cost effective approach to kind of fix this meniscus is outside in approach, wherein you try to approach the meniscus through the outside part of the knee from the medial side, enter into the zone where you want to fix it. This is a PDS suture. So you have got two needles where you want to place it, and then you pass the guide wherein the PDS suture is traced and is pulled through. So once you have it, one from the above, one from the below, then you see that has the PDS suture has entered from above and has gone down. So now that is going to be going to stabilize the bucket handle tear, wherein the flip fragment is now stabilized there, and then again put the similar way, one needle above, one needle below, pass through the cannula and just pull out the PDS and then pull through the other side, and again the second one is gone. So now we have got two PDS sutures which you have got a hold to kind of stabilize it on the medial side of your knee, and then now you can have your so all inside device. So now you can have your all inside device wherein just go back. So now you have got your all inside device. Since you have got the medial side stabilized with the PDS sutures in place, now you put this all inside device directly going through, and then stabilize the root and the body. Probably next to the root is the horn and the body portion. So the posteriorly you are stabilizing that part there. This is the all inside device. Putting the stitch, one in the capsule and the other in the meniscus. And again you place another stitch. So now the meniscus is more or less stabilized. Then people are placing another all inside fixation. One you have already placed it here. Now there is another one you are placing it there. So you are fixing this bucket handle meniscus with the two outside in sutures and then two all inside sutures, stabilizing the meniscus. And now you can see the meniscus is well stabilized, and then you later on go ahead with the ACL reconstruction. But I think one of the important things always when you have an ACL reconstruction plus repair, you better do the tunnels first, because when you do the ACL femoral tunnel, you try to hyperflex the knee. So then there is a chance of giving away of the meniscal sutures. So first do the tunnels and then do the meniscal repair. So this is what I wanted to show. I think outside in is a very cost effective approach. All you need is two needles and then the tracer, which you can bring the PDS out and stabilize the meniscus and put all inside stitches in the horn and the body, and then stabilize the meniscus. So that is what I wanted to show. So another one I wanted to show is the peroneus graft harvesting, which more or less people now started adopting as a common approach. So because now if you see multi-ligament reconstruction, hamstring graft alone is not sufficient. If you want to do PCL plus ACL, always PCL graft. So I think you palpate the lateral malleolus, posterior border. Make sure that you are tracing the peroneus longus tendon. It is just posterior to the malleolus, very easily identified. You got the tendon there. It's a very solid thickness tendon, usually very ideal for PCL reconstructions, because we know that graft failure chances are much higher if the graft diameter is less than 8 mm. So you have got this tendon very much visible, and there's not a big incision needed also. So just put a loop stitch and then try to trace it. Either you can kind of attach it to the brevis part and just or you can just leave it also, but once you trace that, then put a stitch to the brevis tendon. And then once you have it there, then take the stripper. So it's one of the important point is to make sure that we are directing it to the head of the fibula, making sure that we are approaching the right path, and also not avoiding the common peroneal injury. So we kind of here make sure that we are clearing all the adhesions to the tendon.
Arch is collapsed here, no? Middle arch.
Yes, so contraindications for harvesting, particularly peroneus longus, is flat foot and chronic ligament insufficiency.
Is that flat foot now? No.
No, in flat foot should not do because
No. Remove this longest time.
sir.
Put most of the flat.
But it is
So that's what we are doing, a tenodesis here, sir.
Okay.
So with the brevis that moves also the flat.
Interest has come to the medial side.
Yes, so that we are not disturbing.
So you are attaching the rest of the distal part of the longest to the brevis.
So the tension is maintained, the arch is not collapsed. That's where the tenodesis
Arch
starts.
is maintained the longest, right?
Yes.
That is gone.
We are removing, the distal part is still intact, sir, whichever goes to the first
So brevis will what?
Tenodesis.
Right, tendon transfer.
Yes, yes. The length and tension is maintained.
so the reason I wanted to show is because more and more now people started adopting towards peroneus longus tendons as well, because sometimes graft hamstrings can be so thin and maybe sometimes it can be attenuated, so we should always be prepared to have a graft ready for
Especially revisions. Revisions
Especially
also
for
very
revisions.
useful because, and of course there is a lot of debate about taking hamstrings.